So good afternoon. My name is Anita Asgar. I'm live from the Montreal Heart Institute. We're in room number 2. I'm with my fellow from Greece, Theo, and our nurse, Danielle Shikwan. And we have a short case for you, but something we thought would be interesting. So we're going to take you back to basics before you get on to see the complicated PCI. And we're going to talk about hemodynamics today. So maybe if we could show my slides, I'm going to introduce the case for you. So today, right heart catheterization, and we're going to do a CardioMems implantation. So this is a 63-year-old patient with a dilated cardiomyopathy. He's got a previous history of a bicuspid aortic valve with severe aortic insufficiency, and he was operated in 2014 with a surgical aortic valve repair. So not replacement, but repair. At the time he was diagnosed, he also had severe left ventricular dysfunction, had a left ventricular ejection fraction of 25% in 2014. And over the ensuing years, he's had medical treatment with improvement up to 30%. He also had a CRTD implanted in 2019. So his current history, unfortunately over the past several months, he's had progressive dyspnea on exertion, gradual deterioration in functional class, and multiple admissions for decompensated heart failure with elevated NT-proBNPs in the range of 10 to 12,000. So it's a little small, but he is on guideline-directed medical therapy. He's on Lasix, 40 milligrams twice daily, and Entresto maximal dose, dapagliflozin, so an SGLT2 inhibitor, carvedilol max dose, and an MRA, spironolactone at 25 milligrams. And so his ECG shows he's in a paced rhythm. His most recent echo, though, showed a drop in ejection fraction. So he had an ejection fraction of 20%, the ventricles dilated, pulmonary pressures are 57, mean aortic gradient is 30. So we did have this aortic valve repair. He's got a bit of a moderate stenosis with aortic insufficiency, mitral regurgitation at 1 out of 4, and tricuspid regurgitation at 2 out of 4. So basically what we're doing today, this gentleman was approached to participate in a CardioMems implantation to try to maximally manage his medical therapy, to have what we call tailored therapy for heart failure based on hemodynamics. And so to start this, we're going to do a hemodynamic assessment of his heart failure. So a cardiac catheterization, and then we're going to do a CardioMems implantation, so we'll show you that. So next slide. So just to refresh you on the pulmonary artery anatomy, as you can see, right, left pulmonary arteries, multiple branches. Next slide. And so it's really important for us to understand the position of the pulmonary arteries, anterior, posterior, and that's really related to the CardioMems implantation. So for those of you who've never seen one, this is a small implantable monitor we're going to show you. We're going to implant in a distal pulmonary artery, ideally posterior, because the patients are able to transmit the data using a system. It's remote. They lie down on a pillow, and ideally, because it's on a pillow, you want the monitor to be a little bit more posterior so you can transmit the data directly to the healthcare team. Next slide. So why do we put the sensor, the CardioMems device, in the pulmonary artery? Really what we're looking for with this type of monitoring is LV filling pressures. That's the focus we're looking for. Pulmonary artery pressures, particularly the diastolic and the mean, will correlate with that. And we're able to have passive fixation of this device in the pulmonary artery and transmit this hemodynamic data. Next slide. So this is what the sensor looks like. It's got little wings on it and a central sensor, and you're going to see we're going to place this in the pulmonary artery once we've finished the right heart cath, and we will calibrate the sensor with the data that we obtain from the right heart catheterization. Next slide. So you can see the sensor features. It's a very simple, it's a small device, it's very stable, no internal power supply required, and it communicates wirelessly with a small device in this pillow and transmit the data automatically. So this is just some more pictures of the device and particularly the dimensions. So I'm going to stop the slides there, and we're going to start our right heart cath. So we're going to go up. So we have a pigtail already in the aorta. And we're going to start with a multi-purpose catheter, and we're going to go up and get our pressures. As you can see, petit centrer le cœur. As you can see, he has un peu plus haut pour le guide. Juste centrer le cœur. Parfait. So you can see his CRTD system. You can see my pigtail in the aorta. I'm coming up with my multi-purpose catheter. It's really important to take your time to do this. We use minimum 6 French catheters so we can have good pressures. So I always take the pressures as we go up. We want to make sure we see everything. Ideally, a good right heart cath should be done in end expiration. So our patient is awake and we're going to have him breathe for us. On va changer l'échelle à 50, s'il te plaît. And so I like to put my scale at 50. And you can see why, because one of the keys of a good right heart catheterization is to not just take the pressures, but also see the waveforms and understand them. Donc, monsieur, pouvez-vous prendre une grande inspiration? Prenez un grand respire. Expirez. Arrêtez de respirer. Peux-tu le mesurer, s'il te plaît? Mesure-le. Prends une mesure. Respirez normalement. So, Theo, we're looking at these pressure tracings. Tell me what you can anticipate, or what do you see in the right atrial pressure tracing?
We can see here the big A wave. He's in sinus rhythm. The patient is in sinus rhythm, so we expect a wave and a V wave. So he has a pronounced A wave, and the V wave it's less than A wave. So the medium the air pressure is 15. It's a little bit increased.
Right. So what would you take as what's a normal right atrial mean pressure?
It's less than 6 millimeters.
Yeah, it's around 5 and 7. So we're looking at this, obviously looking at the right atrial pressure. We're trying to get a sense of the filling pressures on the right side. And so we've got a mean RA pressure of 13. The patient is awake. We're not under general anesthetic. To your point, we see an A wave and we see a V wave. We're looking at the QRS and the timing to try to understand which is the A wave, which is the V wave. The V wave is actually the slightly bigger one. So we've got a V wave that looks a little bit higher, around 20, depending on, it was a bit lower when we took it in end expiration. But certainly the filling pressures on the right side, at least in the right atrium, are elevated. You agree?
Okay, yeah, of course.
So what we're going to do now is we're going to go into the right ventricle so we can see the pacer leads. We're going to try not to interfere with those. See if we can get in. Okay. Got a little bit of arrhythmia. We're going to see if it stabilizes out. If not, I'm going to change. It doesn't want to stabilize. We're going to find a better spot. Okay. So right now, again, on a scale of 50, we have a right ventricular pressure tracing. We can see the difference. Obviously, the pressures are higher. So when you're looking at this, what do you see? On peut peut-être changer l'échelle à 100, étant donné que c'est un peu plus haut, là. So we've changed the scale, if you heard me say in French. My scale was 50. I'm now at a scale of 100. So Theo, tell me what you see here in the right ventricular pressure tracing.
You see an increased LV and RV and systolic pressure and diastolic pressure. It's the end diastolic pressure is more than 20. It's 22, 21, and the post-ARV RV and diastolic pressure, and it's extremely high. So
right. So I mean, obviously we had an echo which estimated a pulmonary pressure of 57. We now have a right ventricular pressure. So to your point, you can see the A wave on that right ventricle, and the A wave is a little bit elevated, and you can see that you've got an RV systolic pressure of 70, and the end diastolic pressure is high. So we have some questions. First question is, how should the bicuspid valve be managed? Is it contributing to the heart failure? It's an excellent question. He essentially has mixed aortic valve disease. So we know he has bicuspid. We know he had a repair. The valve is leaking. And in addition to that, it's moderately stenosed. And so that's another question to answer here. Should this patient have an intervention for the aortic valve or not? And I think that we are in the process of trying to evaluate that. As well, we're trying to stabilize his heart failure because, as you well know, if you are going to submit a patient for surgery with a lower ejection fraction, we really want to make sure he's optimized prior to surgery. In terms of a wearable device for heart failure, I didn't see the entire question. Wearable device for heart failure management. So the CardioMEMS is not a wearable device. This is an implantable device that we are going to put in the pulmonary artery, and we're going to leave it there. And then the patient will be able to monitor that. The healthcare team will be able to monitor that at a distance. He doesn't actually need to wear anything. We install it, and it just stays there. So we're going to go up into the pulmonary artery. I'm just going to flush my aorta. Try to cause a little less arrhythmia this time if we can. Oh, we've come out. We're going to try to go back in. As you can see, one of the challenges of doing right heart caths in these dilated ventricles, it's not always easy to get where you need to go. So we are in the right ventricle. I'm going to try to get up in the pulmonary artery here. I'll take the wire, please. So based on the right ventricular pressure, would you agree, Theo, he has pulmonary hypertension, obviously? We're going to measure it, but certainly probably higher than what was predicted. So we're in the RVOT. There we go. So we're up in the pulmonary artery. A little bit of arrhythmia as we do that. You can see the dilation in the right side because I've got a nice loop forming in the right atrium. And I'm around my pacemaker. So that may not be optimal. Yeah. So as you can see, I'm around that atrial lead. Now I'm free of the atrial lead. So now we're going to just try to get up there. So we're going to go up and we're going to try to get this loop out. Now, I don't know if you can appreciate that, but we are around that pacemaker, which is not optimal for trying to deploy our CardioMEMS. I think in this particular situation, I can take a pressure here, but this is not an optimal position to be in to implant a CardioMEMS, so we're going to have to pull it back and recross so that we don't have anything going over these pacing wires. Je fais des oxy. We're going to do the saturations because that's how we're going to calculate our cardiac output. Again, more information that needs to be implanted or it needs to be inserted into the monitor so we can have constant monitoring of this patient after the fact. So pressure. This is our pulmonary pressure. Prenez un grand inspire, monsieur. Expirez. Arrêtez de respirer. Peux-tu le prendre, s'il te plaît? So what's our PA pressure there, Theo?
The mean PA pressure is 46. It's high, and the systolic pulmonary pressure is 72.
Right.
And the diastolic is 30. So it's we have high pulmonary pressures, as we expected in a patient like that. With
Flush, please.
yes, of course.
So I would try to wedge, but I think the way this catheter is going around the pacing lead, I'm best to recross so we don't put any stress on this lead. So we have our pressures. I'm going to pull this out. Oh, it's probably good. We're going to do this over the wire to not put any undue traction on this pacemaker lead. It's always a challenge when it's a bit crowded. Okay. Our atrial lead seems to have moved out of position. We're going to try to go back. A lot of gear in here. Okay, we're going to try this again. Okay, So another option here is to just try to make a loop in the atrium and try to get up. And try to make a loop with our catheter, see if it's going to go this way. Obviously, we need to get the CardioMems sheath up into the pulmonary artery. Okay, so we're in the RV. I'm going to try to go up. Obviously, he has a defibrillator. These are often very challenging because we don't want to cause undue arrhythmias. Okay, so we're back up now. Now the key is to try to find a suitable position to put our CardioMem. So as we mentioned, we'd like to be posterior. On va aller à 15 gauche, s'il te plaît. We want to be a little bit more posterior. I'm going to see if we can find a position. We also want to get a wedge because we want to be able to calculate our transpulmonary gradient. Because at 63, it was a very good point to ask about the aortic valve. The other question you have to ask yourself in this particular setting is, at what point do you consider transplant for a patient like this? And so at that point, okay, exactly. Very good question. So is this patient a candidate for transplant? And that's why we really need to try to understand what is the pulmonary vascular resistance, the PAPI, and these are all things we're using now if we're talking about ventricular assistance. I'm not in a wedge yet, so I'm going to take my wire and try to get in a wedge. Pulmonary artery denervation is not something we're doing. We don't have a lot of familiarity with it. I know I've seen some people have done that. But our heart failure team hasn't really embraced that as a potential option. So really what we're looking at, this is a workup to try to better manage this patient. And then, once we have him more stable, really understand what are the therapeutic options for him. So I think transplant certainly is never off the table here, but obviously we'd like to tune him up. And as you can see, we're not quite there, right? We have relatively high RA pressures, still not really in a wedge. We're going to try to find a better position. Prends le guide, s'il te plaît. Just centré encore. This is where patience comes in. Oh, that looks a little bit more promising. Suis-moi. Certainly looks a bit more promising. We're going to flush our catheter. We're going to see. On peut mettre l'échelle de 50, s'il te plaît. We're in an over wedge position, so it's still, that's not bad. I'm going to try to get ourselves in a... Certainly a balloon tip catheter is something else you can use. We have one on backup. I just find a balloon tip catheter is very hard to steer, particularly when I have so much gear in the right atrium. This is a half wedge, half over wedge. This is not a wedge. It's a very tight window. We have a few beats that look like a wedge, and then we kind of go out of a wedge. So this is where a balloon tip catheter would be nice. We're going to come back a little more. The other thing we can do is get the patient to help us with some breathing. Prenez un grand respire, s'il te plaît. Expirez. Arrêtez de respirer. Arrêtez de respirer. Respirez normalement. Still not quite in a wedge here. Certainly try again, or we could try another spot, although I like this one. We'll try a slightly different spot. I think I'm going to need the wire, please. Yeah. Hold on one second. Okay, we're going to take the wire. Montre-moi un peu plus haut, s'il te plaît, Dan. I don't really like the way the catheter is pointing. We're going to try a slightly different position. Yeah. We do want to calculate that pulmonary vascular resistance. So, Theo, remind me how we're going to do that.
We'll calculate the cardiac output and the pressures before and after the pulmonary artery.
Correct.
And we'll calculate the resistances.
Right. So it's really the transpulmonary gradient divided by the cardiac output. So it's going to be the mean wedge, the mean PA minus the mean wedge. So we do need to get a wedge here. So we're going to find a way to get one. If not, the other option is always to put an exchange wire down and take a balloon tip catheter if we are unsuccessful. So we're going to see what we can do. We have kind of a nice position, but we don't. Donne-moi une guide d'échange stiff long. On va ouvrir le criticome. If I'm not able to get a wedge, it is an important thing for me to have here because I do need to calculate that pulmonary vascular resistance. So at this point, you know, I have a good position also for the CardioMems. So what I prefer to do is to put an exchange wire down here and then take a balloon tip catheter because I can titrate so I won't over wedge so much. Because here I'm really between an over wedge or not wedged at all. So the best option, and a stiff wire is what I would recommend. So this is an extra stiff long. Only because a regular exchange wire with this many curves, it's not going to go well. It's not going to be able to give you the support. So I think a stiffer wire is better. So we're going to do this. You can see as I bring my stiff wire down how much movement I have. So we're going to take this out. Okay, peux-tu l'enlever, s'il te plaît? Keep my wire position and just take that out for me. So you have a 6 French criticome catheter, which is an over-the-wire catheter. And we're going to advance this into position. Did we test the balloon before we went in? Okay, balloon has been tested, so we're going to go in. Okay, something is blocking. So let go, you're twisted around. Okay, so just let me advance. Okay, I'm coming up. You can follow me. Centrez, s'il te plaît. Not sure why it's so much resistance. Okay, there we go. Okay, so my balloon tip catheter is down. So you can see that only takes a minute. You know, it's not a long procedure to do. All right, so we're going to aspirate, and now we're going to try to get a wedge here. We're going to pull it back. Balloon is down. Got to make sure I have, so we're already in a wedge position, but we're going to bring it back. So I have good flow back. Excellent. So now we're aspirating well. We're going to flush. We're going to connect and get a pressure. Okay, so we have a PA pressure. We're going to inflate the balloon, and then we're going to advance. So the balloon is up. We're going to try to get a wedge. And here we go. So you can see how fast that is when you actually, you know, have the right equipment. So this is our wedge. We've got respiratory variation. Prenez un grand respire, s'il vous plaît. Expirez. Arrêtez de respirer. Arrêtez de respirer. Prends celle-là, s'il te plaît. Okay, respirez normalement. So you can see here, you've got an elevated wedge. You've got a mean wedge of 30. You've got a V wave of 45. So all V waves don't mean mitral regurgitation. So it's one thing we always have to remember. A high V wave in the left atrium can mean mitral regurgitation, but in a setting of heart failure where we know this patient has 1 plus to 2 plus MR, this is probably more an indication of increased filling pressures, LV noncompliance, a dysfunctional left ventricle, and that's essentially what we see. This is a beautiful wedge. So we can calculate his transpulmonary gradient. We're still waiting on our cardiac output, but we know the transpulmonary gradient is going to be about 14. So that's going to give us, so he's got a cardiac output of 2.8. We've got an index of 1.3. So again, when we're talking about whether we replace the aortic valve or not, we have to put everything into perspective. And this is a dysfunctional left ventricle. We've got noncompliance on the right side. We've got an end diastolic pressure of the right ventricle of 21. We've got pulmonary hypertension. So there's a lot going on here that's not necessarily going to be fixed by just replacing the aortic valve. And we do know that the ventricle's been like this since his first surgery. So we've done this. Now I think we're going to go ahead and try to find a suitable position for our CardioMEMS. So let's see where we are. So now we're going to take some dye and try to figure out if we're in a good spot or not. Non, c'est bon. J'ai pas besoin de donner plus. So I've put the balloon down. We're going to take some images and we're going to see if we're in an adequate position or not for our CardioMEMS. So again, we need to have certain sizes associated. So Evelyn, remind me, what is the optimal size of a PA? Yeah, so we want, you can't hear Evelyn, but we want at least a PA dimension of 7. So we're just going to see where we are. It's smallish. We're going to have to go a little bit more proximal. Okay, so we're going to take a picture here. I'm just going to need a bit more dye. And where the sensor goes, we want at least 10. Okay. Okay, so let's have a look. Take a picture. So our criticum is not optimally positioned. What I'm going to do is it wants to come back, so I'm actually going to inflate the balloon to stop it from moving. Just going to aspirate, make sure I'm not in a wedge. I am a bit of in a wedge. Okay, that's better. The criticum doesn't move, so it's not optimal sometimes. Okay, we're going to try to get a picture here and just see where we are. So it looks like there's a bigger branch that's more vertical. You can see that. We can measure it. So maybe Vicky, if you want to measure that for us. So Vicky is our X-ray technologist who's doing all the measurements behind the scenes for us. Not sure it's that big. I probably would have come in a little bit more. Maybe measure a bit distal, exactly. So she's got 4 distally. A little small for what we want. I did see a bigger branch, more vertical. Can you let that play, Vicky? We're just going to see. I might have to position my catheter somewhere else. Yeah, so you see there's a bigger branch. I don't know if you can appreciate that. That's a little more vertical. What we're going to do is try to get in there if we can. So we're going to come back. So this, like I said, is a bit harder to steer. Je prends une guide 35. I'm going to take a wire and see if I can get myself in that vertical branch. We haven't opened the device yet. I just want to make sure I have a good landing zone before I open it. This is not where we want to be, so we're going to come up a bit. Like I said, this is not easy to steer. Aha! So this is where we want to go. We're going to see, this looks much better for the CardioMEMS. We like something that's vertical. Everything sort of tends to follow much nicer when it's vertical. We're not in a wedge. We'll take some dye. We're going to take a picture here. And hopefully this is going to give us our 7 millimeters. So we can implant this monitor. I'm going to just hold that. Yeah. So that looks a lot more promising. So Vicky, if you want to measure that for me. And we also have the LV lead as a landmark. Theoretically, we're going to need to be below that LV lead. So I like that position. So I'll take my run through. So this device is implanted over a 018 wire. So as you can imagine, very floppy, not a lot of support. We're going to want to get that a little more distal into one of those other smaller branches so that we have enough support to bring the system over. Lots of curves to get up through. So we don't have the luxury of a stiff wire, but we're going to do the best we can with this one. Floppy tip, 018. So this is what we're going to use. So the CardioMems is an over-the-wire system. Just going to make sure that... Okay, so my wire is distal. I'm going to make sure my balloon is down. And then we're going to take out very gently this system without losing our position. I'm going to start pulling this back. I don't mind if my wire curls up. I just don't want to lose my spot. So I'm going to have Theo remove this for me. We're going to keep our eyes on that wire. So just to give you some background information, before you came on, we put in a 7 French sheath in the groin to pre-close with a per-close. We do need a 12 French venous access to put the CardioMems in. So I do have a 12 French catheter, a 12 French sheath, I should say, in the right femoral vein. Okay. All right. Make sure our wire is long. I'm going to take some wet gauze. Je prends des compresses mouillées. I just don't want my wire to move around. Okay, so we're going to take the CardioMems system. I'm going to show it to you on the table with a bowl. So hopefully you can see this. The system comes like this. We need to flush it. Looks like a simple balloon. It's not, but we're going to flush it. Flush the inside. And then we have to activate this in saline. So I'm going to take it out so you can see what it looks like. Okay, you want to take that from me? You don't see the wings, if you remember the wings I showed you on the picture, but this is the actual sensor. Donne-moi des compresses sèches. Je vais les montrer là. Parfait. This is what it looks like. Small. The wings are kind of wrapped around the catheter, and when we're ready to deploy it, the wings will pop out. So this is what it looks like. We do have to activate it in water, so we're going to put it in water. We need to count to 15. Counting to 15. Okay, here we go. So once it's activated, we're going to put it on the wire. It's over the wire system. So I will put it on, and we're going to advance. So the 12 French is obviously for the body of the sensor. The rest of it is quite small, but you do need a 12 French to get this in without damaging it. Okay, so we're going to have a look at our wire here. And we're going to hope this is going to... Peux-tu juste centrer, comme ça je vois le guide. I just need to see. There we go. Beautiful. Thank you. Okay. So we're going to advance over the wire. Okay, the wire should be coming out soon. Okay, so just control my wire for me. Okay, just going to stop for a second, get myself in position. Okay, so we're going to keep an eye on our wire, and I'm going to pinch this and put this in. You have the wire control?
Yes.
Okay, in I go. Okay, so the sensor is in. Watch the slack on the wire. Put a little tension on my wire for me. That's perfect. I'm coming up. You're good? Here we come. You need to negotiate all this anatomy. Up we go. If you remember, our landmark is this LV lead. We need to be below it. And we're below. And we want to be below consistently. You can see how much movement we have with respiration. Just going to advance it just a titch more. There we go. Okay. So I'm happy with that position. Do you want to see any of that? Sorry, I'm talking to my Abbott rep here. Okay. So we're going to deploy this here. So how we deploy this, very simple. There's a blue dial or a blue screw cap. I just unscrew it and then pull it out and gently watch. The wire is still in place. What we don't want to do, actually what I'm going to do is pull back this loop, because what we don't want is a loop to affect the wings when the wings come out. I'm going to pull. I'm going to gently remove. There we go. So I don't know if you can okay. I don't know if you can appreciate it, but it's like a release. So I'm slowly pulling out the rest of the cable. And so we're not done yet because we're still going to have to measure pressures and calibrate this. Doesn't take long, but we do need to do it with the system in place, and we do need to do it invasively. I'm just gently pulling out. Now we're out. Now what we're going to do is going to pull out the catheter. And again, you have to be gentle because we don't want to grab one of the wings and pull the device back. So we're just going to very gently bring this back. Try not to dislodge anything. You can see I don't know if you can appreciate that, but the catheter came back. My device is stable. I'm just going to pull this catheter out. Okay, do you want to pull that back over the wire? Very gently. Watch your wire position. Perfect. Okay, so the deployment catheter, the delivery catheter, I should say, is out. Now what we have to do is actually go back into the pulmonary artery and measure the pressures, and we're going to calibrate this. So again, we don't want to dislodge anything. Probably the best thing to do is take the criticome. So we'll take the balloon tip catheter again. We'll go back over the wire, but we don't want to go too close to the device. You're going to see as I come up, I'm going to move to a slightly different position. And then we're going to calibrate, and we're going to put this pancake-like device underneath the patient, and the machine's going to read, and we're going to see how we are with our signal. On peut on laisse comme ça. Okay, so we're going to see our wire position. We're good. I'm coming up. Hold a little bit of tension for me, and I'm coming back up. So, you just have to be careful. The last step of this is to pull out the 018 wire. What you don't want to do is hook the device. I just need to make sure that it's straight. So I'm just going to leave that up there. You can leave the wire, and I'm just going to pull this back. Okay. I don't want to hook anything. I just want to come out. Okay, so now I'm out. There we go. Okay, so now we can actually measure the pressures, and we're going to calibrate. As you can see, depending on the center you're in, sometimes heart failure specialists that put this in. In our center, it's interventional cardiologists. We can manage all sorts of unforeseen complications if need be, and I think we know our equipment very well. So one of the really interesting things, if you look at this PA pressure trace in green, you see that second notch on the PA pressure trace, and that's that V wave that we saw in the wedge around 45, 44. It's got a little bit of arrhythmias, but you can see that well. On peut juste monter le tube. Elle va mettre l'affaire. So she's going to put the calibrating disc underneath the patient. And we will calibrate by me measuring a PA pressure. She's going to enter that in the computer. Tu peux le mettre en AP, en fait. So she's a good signal. So how much contrast use are you targeting? Very good question. We use very little contrast. I think a total I might have given 15 cc's just to do the pulmonary angiogram. So we are diluting the contrast 1:2. The one reason I like to do that is I find it gets a bit sticky. The wires and everything gets sticky. So dilute the contrast 50-50. So far, I think I've used maybe maximum 20 cc's of contrast. The procedure, is it reimbursed? Not entirely in Canada. Every region in Canada is somewhat different. In Alberta, this is reimbursed, but unfortunately not in Quebec, not yet. So this is still part of a bit of a research protocol. We're waiting to see, I'll show you some data on hospital readmissions. Do you have a good signal? My mean is 39. So she's got a good signal on her machine, so she's going to enter the data. And this is what we're doing. We're doing the calibration. So when the patient is home with his pillow, we've already been calibrated, and we'll know the data is accurate. Just going to take a cine image so you can see what that looks like. So that's the pancake. You can see the little oblong feature with the 2 dots on either side. That's our CardioMems. Sorry? 41. $62, $24, $41. So I'm just reading out the pressures to her so she can do the calibration. 41. They have the cardiac output. The nurses are going to be able to give that to you. It was 2.8 with an index, I think, of 1.3. $65, $23, $42. $42. So as we finish up calibrating, we will remove the catheters, and we have a radial. We'll take out the radial, and then we'll close the femoral. So 1 per close. We pre-close the device, pre-close the vein, and then we'll just take out the 12 French and close. And then the next step for this particular patient, optimization as much as possible, the medical treatment. We've gotten the data. I'm just waiting for them to calculate the PVR for me. I don't know if they can show me the pulmonary vascular resistance based on the data that we've accumulated. And really, once he's optimized, decide, what's the next best course of action. So I think if there's going to be a surgical intervention that's going to have to happen here, it's really going to have to be considered something more definitive, I think, than aortic valve replacement, but perhaps considering, advanced therapies, be it mechanical assistance or transplant. He's still 63, so. Last reading, 73, 23, 41. So maybe going back to my slides, there's just a couple of things I thought were interesting that I wanted to share with you while we're doing this calibration. Don't see the slides. Don't know if it's possible to bring those back. Yep, we can remove the antenna. So we're going to take out that antenna. So the calibration is done. OK, on va baisser le tube. Okay, I'm going to take out this PA catheter. Just going to pull it out very gently. Okay, so the PA catheter's out. We're going to remove our pigtail. I'd like to see my slides again if possible. Just want to share a couple of other pieces of information with you if it's possible. Perfect. So if you just go to the next slide. So I'm going to let Theo close our access, or at least take out our pigtail in the aorta. So this is just a little bit about more how the device works. It's a wire loop function, silicone outer coating, stays in the vessel. Next slide. This is the delivery system which you've seen. Very simple, but it is over the wire. Next slide. So what I really want to show you is just a couple of slides that I borrowed from Joanne Lindenfeld, and she presented this at THT, the heart failure meeting. Next slide. And what I think is really interesting is if you look at these three studies looked at the management of patients with heart failure, reduced ejection fraction. In the red is those patients. So on the right, it's, I think, recurrent hospitalizations or death or hospitalizations, super small. And what you can see is the red and the blue. The red is, I think, standard medical treatment, and the blue is treatment guided with CardioMems or guided hemodynamically. And what you can see relatively consistently is an improvement in these patients when we have a hemodynamic way of monitoring them and adjusting their therapy. So next slide. This is a little bit bigger, but a 25% reduction in mortality at 12 months in the treatment group. And so what is the treatment group in these studies? The treatment group is hemodynamic guided monitoring of medical therapy and adjustment of medical therapy. And so the monitor itself isn't changing mortality, but it is helping you to treat these patients better so that you can impact the mortality. Next slide. So again, you see this consistently, multiple different trials. Next slide. So significant, and in addition, reduction in heart failure hospitalization. So he's the ideal patient for this kind of treatment. He's been back and forth for intravenous Lasix, for admissions. And, hopefully by using some non-invasive monitoring, we can get him better medical therapy and he will be able to be more stable so that we can move on to the next step, which is going to be his definitive treatment. Next slide. So again, at 38% reduction in heart failure hospitalizations at 1 year. Unfortunately, we don't have reimbursement for this. We're really hoping we're going to get it. You can see these numbers, and there's no reason why we shouldn't have it. Next slide. So you've seen what we've done, vascular access. We did a right heart cath. We started with a multi-purpose catheter. As you can see, some of the difficulties with a multi-purpose catheter, we couldn't get a great wedge. Put a stiff exchange wire in, changed for a balloon tip catheter. Got a very nice wedge. We've calculated the cardiac output. We did a pulmonary angiogram, very targeted pulmonary angiogram to find a right position for our CardioMems, and then we implanted it, which took, all of 7 minutes to do. Next slide. So these are the steps of the procedure. Obviously, gain access to the PA, do an angiogram, cannulate the target vessel, deploy the sensor, remove everything, and then calibrate the sensor. 6 steps. Doesn't take terribly long, but it is important to do this in a systematic fashion, evaluate all the pressures. We're not here just to implant the device, we're also here to understand the hemodynamics. I think the next slide. So, this is basically what we've tried to show you in 45 minutes, a little bit different than what we've shown you in the past. But I do think something interesting, heart failure is a growing problem globally. We need to find better ways to treat these patients. And hemodynamic monitoring may be a way to at least tailor medical therapy, and we've seen improvements in terms of heart failure hospitalizations and mortality. So we're just going to take out everything now. So the pigtail catheter is out. I'm going to close up the vein. So we did a pre-close with a per-close device. We're just going to close this up, and we're going to be done. Okay. You could take the wire out. I don't need that. Okay. I'm just going to take out my 12 French. Je vais peut-être mettre un petit point dans la peau. I'm just going to put a little suture in the skin. That's it. I'm going to put a small suture in the skin. Probably don't even need to, but I will do it. And now we're done. So took a little bit longer than I thought, but I hope that was useful for you. I don't know, Theo, if you had any other thoughts. Not a very difficult procedure, but important to understand the hemodynamics in these patients.
Yeah, it was very productive, and it was a nice experience. Yes.
Yeah. All right. Well, thanks so much.
Thank you very much.
I think room 1 hopefully is going to be ready for you soon. We're just going to close up the small incision here, and we're done. Je prends la bistouri, s'il te plaît.